Hello, good morning, America. Good afternoon, Europe, Africa, and good evening, Asia and Australasia. My name is Napapong Pongnapang, ISRRT Vice President for Asia and Australasia. I am your host today. And tonight in Asia time, we have a very special Facebook event to share with you all around the world. Today, this is the first collaborative Facebook webinar between ISRRT and Taiwan. The topic of today's webinar is Radiographers Mammography Education, Training and Professional Practice Requirements, Taiwan's Experience. Taiwan has been valuable member society to ISRRT throughout the years, and the radiological technologies education, training, and professional practice is one of the most advanced places in the world. With the unique education and licensing system, Taiwan is one of the leaders in our region. And again, this episode is the collaborative work between ISRRT and the two Taiwanese society, TWSRT, Taiwan Society of Radiological Technologists, and TAMRT, Taiwan Association of Medical Radiation Technologists. And today we are honored to have the two presidents of the Taiwanese society to join us as the guest of honor. First, I would like to welcome President of the Taiwan Association of Medical Radiation Technologists, TAMRT, Chun Yuan Du, to give a word to the members of ISRRT around the world. Please welcome President Du.
Thank you, President Donald, Dr. Napapong, invited speaker, ladies and gentlemen, good day. It's a great honor for me to make a welcome speech for ISRRT Facebook Live. TMRT's board member includes all of the radiographers in Taiwan, and the TMRT has been in charge of the project of Atomic Energy Council, Executive Yuan, and Ms. Tan is the program manager of the Mammography QC. Today, Ms. Tan will give a speech to share our experience. Thank you.
Thank you, President. And we also have our long time member, TWSRT, the Taiwan Society of Radiological Technologists. We have the recently elected president, President Vincent Guowei Wang. Please welcome President Wang.
You're muted.
President Wang, can you unmute your microphone, please?
Okay. Hello?
Yes.
You hear me?
Yes.
Okay. Good afternoon, our honorable hosts, Ms. Newman and Mr. Napapong. On behalf of TWSRT, I'm much delighted to be invited today to join this meaningful online seminar. And actually, TWSRT was established on April 27, 1949, and it is composed of medical radiologists from all over the country of Taiwan who are engaged in radiological technology work. And it has been carefully managed by previous director, and the current number of members is about 1,720. Yeah, we're back to the seminar. This seminar has invited several distinguished international scholars to address issues in mammography and to share their experience. Today, Taiwan speaker Ms. Tan also expert in mammography, and I cannot wait much longer to listen to their excellent speech and wish the seminar has full success. So I now back the floor to the host. Okay.
Thank you. Thank you, President Wang. And now it's time for our President, Donna Newman, to have some words to Taiwan members and also the members all around the world. Please welcome Donna Newman.
Welcome, everybody. I am so excited today to be hosting this session with both the Taiwan presidents. I think it is just a great moment for us. We know that they have been a valued member in our council, at our world congresses, and through support throughout the ISRRT. I can't tell you what a role model and leader you've been in your handling of the COVID virus. And I just thank you for sharing your expertise with the world and your best practices. I know many of our members have benefited from the information that you have provided through our links. So I thank you for that. I thank you for agreeing to host this. And I'm excited today to showcase your country. So I will turn this back over to Napapong to introduce our speaker. And I look forward to the panel discussion with all of you. Thank you so much.
Thank you, Donna, and thank you, President Du and President Wang. I would like to officially say hello to my Taiwanese friend, Taiwan, 大家好. All right, now we have to introduce our speaker. Our speaker today is Miss Tang Yunshuan, and she is from Taiwan. Her education is she received the Bachelor of Science in Radiological Science from Isho University in Taiwan, and MA from the Department of Biomedical Engineering and Imaging and Radiological Science from National Yangming University also in Taiwan. She has numbers of working experience, and at the moment she is the medical radiation technologist at Chin Kong Memorial Wuhoshu Hospital in Taiwan, and also she is mammography image reviewer at the Health Promotion Administration, Ministry of Health and Welfare, and also she is academic research commissioner for the Taiwan Association of Medical Radiation Technologists. And today, she has other credentials that she has a lot of experience in this field, and she would like to share to the world about the Taiwan experience in mammography education, training, and professional practice. And please welcome Ms. Tang.
Hi. Thank you, everyone. Thank you, Napapo. Let me first of all thank you for your every kind introduction. And today I want to talk about some of our work in the field of Taiwan's experience about mammography education and training and practice. Thank you. Hi everyone, my name is Tang Yunshuan, the member of Taiwan Association of Medical Radiation Technologists. It's a pleasure for me to be here. I am very glad to have this opportunity to share mammography radiographers' experience in Taiwan. I have divided my presentation into 3 parts. I'm going to start with the technique of mammography radiographer. Then I will talk about the mammography quality control. And finally, what on-site inspection we got now. In the world, most 30 women die of breast cancer each year. The most common type of cancer on the list is breast cancer. And the next most common cancer are lung cancer and prostate cancer. Breast cancer became the most common cancer globally as of 2021, accounting for 12% of all new annual cancer cases worldwide, according to the WHO. The results of previous studies have shown that compared with patients who have never been screened, among women in the screening group, there was a 28% reduction in mortality from breast cancer during the same period. After national breast cancer screening programs were implemented, Hong Kong, Japan, Taiwan have breast cancer incidence that are as high as any Western countries. I think as breast cancer screening becomes common disease, the incidence will likely go up because there will be detecting more cancer earlier. In Taiwan, according to the medical evidence, for women as well as subsets of mammography once every 2 years for patients aged 45 to 69 or patients aged 40 to 44. With family history of breast cancer to protect the health of women's breast. It means any one of the patient's grandmothers, mother, daughter, or sister has ever suffered from breast cancer. The latest report number of breast cancer screening rate above 40%. That breast cancer has a high cure rate if detected and treated early. And the first stage patient survival rate is up to 96%. From 2011 to 2019, the overall mortality of breast cancer is approximately 22.2% among Taiwan females. According to data from the Taiwan Health Promotion Administration, the screen rate is only about 40% in Taiwan among women who are eligible for free screening. One would expect the rate to be higher, so what's keeping them from getting a free breast screening? There are three possible reasons. To begin with, performing a regular self-examination sounds adequate for most women. Secondly, some may think having a chest X-ray is enough. Thirdly, for those with no family history, the notion of breast cancer seems vague and thus free screening draws little attention to them. Truth: a self-examination sometimes fails to detect early signs of breast cancer, and chest X-rays are usually for detecting the problems in the lungs, ribs, or other organs. And only 10 to 20% of all breast cancer cases are seen on the chest. Since 2009, mobile breast screening facility has been developed and has influenced the breast screening service. Mobile mammography vehicle allows care providers to increase their capacity for service delivered outside of this clinic, which is particularly important in areas without an infrastructure for cancer screening service. Mobile mammography increases community access by offering screening in convenient locations, thus decreasing the distance and travel time needed to access screening service. Mammography screening the first and best line of defense in detecting breast cancer early. We have 252 direct digital mammography, 55 computed radiography, and 51 digital breast tomosynthesis. In 2020, 18.6% digital mobile mammography facility and 51.4% fixed mammography were operational in Taiwan. So, how do you get started in mammography in Taiwan? You have been certified in general radiography. Secondly, you will need to complete and document 40 hours of training and education specific to mammography under the supervision of a qualified instructor. Thirdly, you must perform a standard image under the supervision of a qualified mammography technologist or radiologist. I would like to refer to the image C. This showcases the perfect image quality. Continued medical education programs for radiographers have the benefit for increase the early detection of cancers. They need to requirement of 10 hours of mammography training course. Image review include rendering and self-select mammogram. What is the standard for evaluation? The standard was developed by UK Mammography Trainers Group. Reduction in breast cancer mortality from mammography screening is highly dependent upon the consistent production of high-quality images to enable the early detection and therefore treatment of cancers. To this end, countries with breast screening programs such as Australia, the European Union, Hong Kong, and Taiwan have established minimal image quality standards. Specifically, in these screening programs, mammography image quality of the two routine view, the cranial corridor is mean CC view, and medial lateral oblique is mean MLO view, and radiographer performance are assessed and monitored through the use of the PGMI image evaluation system, is mean PGMI IES. For CC view, the position criteria. First, medical border well demonstrated. Second, nipple in profile or skin edge seen transiting nipple. Third, nipple in midline of image breast. And posterior nipple line with 1 cm of PNL on MLO view. For MLO view, the position criteria. First, pectoral muscle shadow to nipple level. Second, full width of pectoral muscle. Third, nipple in profile or skin edge seen transiting nipple. Fourth, inframammary angle well demonstrated. And finally, PNL with 1 cm of PNL on CC view. Both CC and MLO view meet criteria for image. Corrected image identification, corrected exposure for modality, adequate compression, absence of movement, corrected image processing, artifact a skin fold which doesn't obscure the image, asymmetrical images, with the PGMI IES playing such an important role in audit standard, ensuring that standard requirement accurately reflect achievable image in clinical practice is essential. In Taiwan, mammography radiographer has to receive check for the image random and self-select each year. Each group of breast image is 2 CC views and 2 MLO views. Greater than or equal 360 is level A. 340 to 359 score is level B. 321 to 339 scores is level C. And less than or equal 320 is level D. Level A and Level B requirement 10 hours mammography training course each year. However, Grade B need to finish 2 hours about image quality. What if the score is Level C? You must be finished 40 hours training course and 2-hour image quality course before next check. If you get Level D, you can operate a mammography technique unless you finish the 40 hours training course. I would like to begin by looking at the table. Based on radiology check result last year, 25.8% of radiographer is level A, 73.8% is level B, only 0.4% is level C. As you can see, self-select image data from table. There are 48.9% radiographer in the level A and 50.9% in the level B, but only 0.2% in the level C. From this table, we can see level B of random select has the biggest piece. About 50% of the level A and B in the self-select images. All in all, the radiographer in Taiwan done very well with the random or self-select images. No matter how sharp the breast, they still take standard images for patients. Read on to see example mammography images and to learn more about what the low grade. Next, I'm going to share the mammography with grade C. There are 3 pieces of issue in this image. First of all, Peso muscle width doesn't exceed the half width of soft tissue, and the width of peso muscle doesn't exceed the extension line behind the nipple. So, the adipose area between granule and peso muscle can be shown completely. Second, nipple fall from breast position may obscure visualization on breast tissue around nipple. Because the incidence of breast cancer under the nipple and areola area is 1 to 4%. So, missing this area will deduct more points. Third, the inflammatory fall under the breast should be clearly visible. The radiologist can know the end of the oral breast tissue from the image when the radiographers position completely illustrated the INF area. This is the second example for the mammography with grade C. There are also 3 issues that we need to know. Same as previous case, peso muscle width doesn't exceed the half width of soft tissue, and the width of peso muscle doesn't exceed the extension line behind the nipple. The glandular region can be completely diagnosed due to the fatty tissue overlap the glandular region. The second issue, this skin fall, will affect the diagnosis accuracy and glandular distribution, and those areas even overlap the microcalcification. Moreover, the nipple is completely visual in the skin cut area. The third issue is INF can be seen from the image, but the INF has not expanded. Although you can get the boundary of glandular distribution area, but the 4 regional may obscure abnormal lesions. It can be shown completely. There is a case I can share with you. This image shows a case from our hospital. The radiologist suddenly found a protrusion on the lower edge of the breast during the position process. The patient didn't feel any discomfort and touch any mass. After the radiographer has performed the routine mammography, the radiographer suggests that the patient recheck whether there is an abnormality in the lower edge. After the patient expresses his willingness, the radiographer sticks BB mark on the lower edge of the breast and using MRI view to measure the abnormal area. It was found that there was indeed an abnormal area. Moreover, the radiologist used the span mold and pulled out the INF completely to find that there was indeed a lesion. Later, the patient was referred to the outpatient clinic and biopsy. The result of the breast cancer test is DCIS. To this case, pull out the INF tissue can increase the diagnosis accuracy. Next, I'm going to introduce grade D image. There are lots of folds in it. We will check 3 major parts which the position isn't posed well. First of all, peso muscle is over half of the axilla, but depth isn't achieved PNL and the fall of axilla is serious. Second, the nipple isn't in line with skin and is fall down and hide the glandular. Third, the area is INF. As you can see, even though the technique has present INF, the INF is not clear enough. The point of the image is breast, which can be interpretation. The skin folds are too many, and the image of breast isn't clear. This image should not appear in any radiographer who training with clinical breast professional training. Therefore, the evaluation committee gave a D for this image. From the above, Taiwan's mammography radiographers are subject to a certain degree of supervision in clinical training, as follows with 1. Obtain knowledge to help prepare for the mammography exam. 2. Demonstrated basic position skill for the CC and MLO view. 3. Advanced position technique for supplementary views and even improve. 4. Perform mammography quality control testing procedure per guideline. 5. Describe newly imaging technologies used with digital mammography imaging. These skills and knowledge are Taiwan's mammography radiographers should understand and proficient. The current document is the result of a review of current overseas practice and local experience in this area. At this time, the technology of digital image is undergoing significant development, and there is still a lack of full international consensus about some of the detailed quality control tests that should be included in quality assurance program. In the last 2 decades, comprehensive guidelines on quality control in mammography have been developed worldwide. It's therefore very critical that the quality control and acceptance tests of digital systems, such as conventional mammography systems, are conducted carefully and periodically. At the advent of digital mammography, efforts were made to revise quality assurance guidelines for mammography and advance in line with technological advancement. Specifically, the criteria used in the phantom-based image quality assessment, which were previously followed, were revised and new phantom designs were created in some cases. At the end of these efforts, which dated approximately 10 years, a conclusion was reached on the protocol revision. The variation included tests performed, phantom use, image quality criteria, and limit value. The variation at these points may result in non-homogeneous test results, hence differing results in different countries using the same equipment. Let's make a quick review of the ISRRT guideline. The Mammography Quality Standard Act of 1992 was enacted to set federal quality standards for all aspects of mammography. A detailed technique evaluation of products, measurement of the limits of the unit, or optimization of the unit are not the primary aims. However, they are important. According to ISRRT, the primary aim of quality control is to reduce the irradiation exposure of patient and personnel, ensure a suitable and consistent image quality, and identify and correct a potential problem before they impact the patient's image quality. ISRRT established a semi-annual quality assurance for mammography, especially in primary rules. They also have the common points is that every quality assurance procedure needs to perform with quality of the equipment, like a calibrated dosimeter and standard breast phantom, before performing quality procedure, and confirming that there is no problem to execute the clinical procedure. There are guidelines that are organized from the different countries and institutions. Those guidelines that we mainly follow around the world from 4 different institutions. This table also shows the same protocol on quality control procedure, but those guidelines have different executed time points. For example, the manufacturer suggested the daily phantom image quality test, but The suggestion from ACR and IAEA is weekly. The possible reason is that some manufacturers have more stringent requirements for equipment. For the public vision from institutions or organizations to achieve the minimum standard requirement, the guidelines should consider different manufacturers' imaging modality and specification. This table shows the execution frequency in semi-annual quality assurance procedure from different manufacturers. Giotto and Siemens suggested that the ACR phantom image check should be performed daily. The ACR, MQACA, and IAEA suggest to perform yearly. Most manufacturers increase the frequency of quality control, keep that can provide the best image quality. Based on the above, although the guidelines doesn't call for mandatory practice of these 6 components of quality control, most manufacturers have incorporated them into their SOP of semi-annual quality control to ensure stable performance of the equipment and quality of the images. You may wonder what these quality control tools are about. Now I will give you a brief introduction of the SOP of quality control. We start by making sure the machine works properly. Lots of possible malfunction can be excluded beforehand by using this checklist. The items of the list are related to safety and image quality. Let's take these 2 items for example. Collimator light working and petal phase shield. A non-functional collimator light working can lead to improper position and affect quality, whereas uncorrect petal phase shield endangers patient safety. This is also why QC menu of many equipment suggests a routine check-up of the machine prior to using them. Mammography is a high-resolution medical image. Require higher standards for displays. In order for radiographer to reduce artifact and to make sure image clear enough, 2 common parameters are used for calibrating displays. The spatial measurement for the quantitative evaluation of geometric distortions using the TG18 QC test pattern. The small square with dashed line define the 4 quadrants of the pattern, and the large square at the center encompassing the luminous patches is the one to be used for geometric distortion with the whole image. The second parameter evaluates whether the detectors are equal distributed, with the same window width and window level as used above. Evaluated the entire image for overall appearance and for artifacts. Many radiologists and technologists are unfamiliar with artifacts that are commonly seen with this modality, and recognizing these artifacts is critical for optimizing image quality. Commonly encountered artifacts include patient-related artifacts, hardware-related artifacts, and software processing artifacts. For patient-related artifacts, for example, motion artifacts, antiperspirant artifacts, thin breast artifacts, and about hardware-related artifacts, for example, field non-homogeneity, detector-associated artifact, collimator misalignment, underexposure, grid light, grid misplacement, vibration artifact. Finally, software processing artifact. like breast with a breast artifact, vertical processing bar, loss of age, high-density artifact. It's important that the technologists, the spectrum of digital mammography artifact, and pay careful attention to digital quality control procedure to ensure optimal image quality. Quality control procedure is most important for mammography. By executing those procedures and evaluated phantom image, that can help optimize the mammography system image quality and performance. The whole procedure is followed by MQSA specification. Below are phantom used during mammography. The one on the left side is more commonly used today. The one on the right side is newer version developed in recent years. Fibers, specs, and mass all have their respective score in both phantoms, and every manufacturer needs to go through the process of ensuring image quality by evaluating the scores using the phantom. In general, the detector must warm up for 10 minutes. To avoid this non-uniformity, we need to use qualified and correctly manufactured phantom. Use of an improperly manufactured phantom can result in a phantom score that doesn't accurately reflect a mammography unit's true performance. Some DR detectors may have a non-uniform response. For example, due to variation in sensitivity, over 40 pixels. Also, there are non-uniformity in the X-ray beam due to the N-hill effect and X-ray beam divergence. DR system correct for this inherent non-uniformity by a process of flat fielding. Flat field correcting maps are obtained using a standard beam attenuator for one or more exposure conditions. For example, different target filter combination and focal spot size. It's a flat field test. The flat field test is performed weekly to test detector function. This involves placing PMMA on the detector. For example, 2.5 cm for Gini unit and 4 cm for horological unit. Over the entire detector with non-compression and then taking an exposure. If detector is non-uniformity, the 5 regions of interest are brightness non-uniformity, ISRRT non-uniformity, and bad pixel verification. Brightness uniformity checks the magnitude of low-frequency structure. ISRRT non-uniformity assesses the variation of ISRRT across the image. Bad ROI counts the number of ROI having 2 or more bad pixels. Bad pixel verification measures the number of pixels having signal differing from adjacent pixels. Of these parameters, bad ROI is the most common to fail. This should be checked with the least 3 thickness of PMMA, covering the clinical range used. The range of thickness used must ensure that all clinically used target filters are tested. A benefit with the proposed AEC that the risk of underexposing the densest region of the breast can be visually eliminated. The exposure technique was recorded according to the clinical conditions of each institution. These were obtained with AEC for the different PMMA thickness. CNR is a measure of the detector's ability to distinguish between objects in an image and image noise. There are 2 methods to measure CNR until now. The left side, Images were taken under manual exposure conditions, which include an additional 0.2 mm aluminum sheets in the European guideline. The standard value equal over 40. The right side, images were taken by using ACR phantom. The standard value of CNR is mass and background ratio. It must be equal over 2. The height of the aluminum above the phantom is not critical, and it can be sandwiched between P and MMA. Early experience of changing from analog to digital has shown that the number of repeat images may increase initially. A log of all repeat examinations must therefore be kept and regularly audited. The design of the PACE digital system should allow for repeat and reject analysis. It's common reason of right image. One of the advised QC tests is reject analysis, as this is an expensive method of gaining information related to image quality, revealing deficits in service and consequently bringing about a reduction in reject images, dose and financial burden. Reject rate recommend rates by all retrieve guidelines. That is less than 3%. Other guidelines indicate a reject rate of 5% as being acceptable, but decided a 2% rate as being achievable. Painful compression to the breast has always been the biggest downside to mammography. It's the most important reason behind low screen rate. Women tend to reject the study next time due to pain. In fact, some may even unconsciously decline the exam because of their family members' unpleasant experience or negative comments on the internet from other patients. But if we ease the compression to make patients more comfortable, it reduces accuracy and affects the quality of the study. Therefore, precision of the weight applied during mammography also influences image quality. To ensure optimal outcome with compliance to quality control, compressive weight should be between 11 to 20 kg. Radiographers play a critical role in terms of image quality and maintenance of related equipment. In addition, we work hard to reduce women's fear to mammography and increase screen rate. Radiographer activities should be analyzed. Focus on the manipulation of other medical imaging devices and workstations, but also evaluating the noise, temperature, impact of monitor in visual performance and patient handling. In 2020, Atomic Energy Council appointed Taiwan Association of Medical Radiation Technologists to inspect on-site mammography setting and equipment. Randomly 15 mammography units were selected across Taiwan. 2 ACR phantom score, variation of KVP output, and MGD measurement were collected to assess correct quality control of mammography equipment in Taiwan. The figure below shows 15 units, including CR and DR, using auto exposure mode to image 2 phantoms. Scores of this image are average. Let's first take a look at how CR and DR each performs using DM phantom. We can see that DR is superior in total score than CR with regard to fiber, specs, and mass. The same is observed for FFDM. In conclusion, DR is better than CR regardless of which phantom is used. Mainly, it's due to difference in detector and image conversion. You can see from this figure that among the 50 equipment segments, CV is below 0.004 in both DR and CR, which is far less than the standard 0.02, and this helps ensure the quality of KVP output. Mean gradual dose is a quality used to describe the absolute dose of radiation to the breast in mammography. Breast phantom, which represents a breast composed of 50% fat and 50% glandular tissue, and compressed to 42 mm thickness, should be used to determine the representative mean gradual dose for a breast of a similar composition. The mean gradual dose should not exceed 3 mg. This figure points out that in all 50 units, the MGD of DR is far less than that of CR. However, among them, 2 CR units exceed 3 mg. This data is forwarded to Atomic Energy Council, who then require that improvement be made by the institution using these 2 CR units. Afterward, reassessment is conducted and both pass the exam. Whereas all 50 units meet the standard of image quality and CV of KVP, 2 of them fail to pass the MGD test. I believe radiographers may contribute to the performance of QC and evaluated by the designated QC technologist. And our future work is to create a designated lead QC technologist is responsible for ensuring that tests are done properly by standardizing test methodology, reviewing all data, overseeing repeat testing. Thank you all for listening. It was a pleasure having you. I'd be great if you have other questions. Please email me.
Thank you, Vivian, for your very, very comprehensive and excellent talk. And this is an eye-opening, I believe, for your colleague, for our colleague from different part of the world, where the practice of radiographers and technologists vary from one place to another. And in my opinion, this is proof that Taiwan is one of the leader in the field, because you have standard of practice and also education and training from the start, from your education, your certification, your advanced practice, and also your role that fulfill the requirement of the excellence work that we provide to our patient. We got some questions from the audience, and I think President Tu and President Wang can also answer the question if it related to your organization. I will speak slowly. All right. The first question is from the Philippines, Peachy Luna from the Philippines, our good friend. The question is, what are requirements for the female technologists to practice mammography in Taiwan? Do you have any special certification for those technologists to perform mammogram in Taiwan? And specifically an issue about QA and QC testing. Maybe, Vivian, you want to start first? Any requirement?
The question is ask me about the quality control, right?
No. The first question is, what are requirements for technologists or for radiographers to practice mammogram in Taiwan? Maybe your president can help you.
In Taiwan, the mammography radiographers need to have 40 hours training course, and need to 10 hours about the image quality and manufacturer quality control training course. If you want to pass if you want to get the certification, you need to post the exam about the training course and the quality control course. And then you need to send your image to the Taiwan Medical Association to get the certification. So I think in Taiwan, every mammography radiographer can get it because they have a good supervisor to introduce them, and some girl they can reading more clinical image, and our data will take you about the image quality and then the image diagnosis. Yeah.
All right. Maybe President Tu, you can add something more about the role of your professional organization in terms of providing education, training, and certification for this issue.
Okay, I will talk first. Ms. Tang is talk about advanced training. In Taiwan, we have the basic training. The basic training is our female radiographer. We have 2 years PGY training for new staff. Register for training for 1 week or 2 weeks for the mammography. And then when they finish the training, they will get to the Ms. Tang to talk about the advanced. The training for the 40 hours or 100 hours. That's all. Okay.
Oh, you mean after the radiologic technology student finish the bachelor degree, they need 2 extra years of clinical training program, or? Yeah. After student program, we have a new staff training program for 2 years. Yeah. Is it compulsory by the TAMRT? Yeah, it's for the TMRT, yeah. Oh, okay. This is quite interesting because in our country, we have similar system like what you do in Taiwan, but we are looking for additional training here also because we do 3-in-1, like 4 years program. We do diagnostic, therapeutic, and nuclear medicine, but clinical attachment is very limited. Then I think postgraduate training year is quite interesting way to ensure that our people have enough competency to perform in the field. Back to the TWSRT, what is the role of your professional society in terms of providing this education and training in Taiwan, or what have you done so far?
I think
So just to clarify my question, basically TAMRT is more like on regulatory side, right? You control the practice, you control the licensing, but the TWSRT is professional society, where you have the activities with your members. For example, you have the conference and so on. Is that correct?
Here in Taiwan, we got a small conflict. The TWSRT did not provide any mammography education to training the radiographer. Now, here in Taiwan, yeah.
Okay.
Can I add to that, Napa?
Yes.
I would like to. Yeah, I'd be very interested to know from our presidents, do you have where the radiographers or mammographers in your country, once they're done with their training, their 2 years, then do you ask them to do some professional development, continuing professional development on mammography every so many years? Do you guys help provide that? Is that done through their hospitals or through your organizations? How does that work after they've been certified or are done with their clinical training? how do they keep up with the technology?
Yeah, actually, okay, Mr. Drew, you speak. Okay. Okay. Actually, here in Taiwan, the female radiographer have to maintain their approval periodically. Yeah, and send back his own mammograph image to the official, and we have a form to make a score. If the score is under the average, then we have the female radiographer must receive the retraining course. Okay.
About 10 hours.
Okay.
Okay. So you have like continuing professional development, right? The CPD.
Yes.
Very good.
Okay.
Very,
good.
very good program.
I
Yes.
got another question. This is quite interesting because when Vivian presented about the quality control part, some of the items that the technologists in Taiwan perform are the items that the medical physicists in other countries are responsible. So the question from Donna, I think Donna asked the question about, does the physicist work with us, radiographers, in performing annual QC testing for the mammography machine?
Actually, in Taiwan, the same quality control always radiographer to do it. Yes, but a new quality control almost the engineer to do it or medical physicist. But our future work hope our radiographer can do it because we are always work in a clinical, right? But if we don't know how to get a solution about image quality or about manufacturer maybe fail, we can fix it, and maybe need to maybe the patient will need to waiting you to fix the machine or to get a solution about image quality, maybe about an artifact. So we hope and maybe our future work hope our radiographer can to do it. Future work, okay.
All right. Any comments from the two president? Like this is quite interesting because like we want to know who is responsible for the annual test, yourself or the physicist.
I can explain the situation in Taiwan. In the first, in our country, our medical staff need to pass the national examination, and in Taiwan now we don't have the medical physics national examination, so we don't have any medical physics to help us to do this quality control. Okay, so maybe in the future, in our country, we'll have the medical physics.
Okay, quite interesting. And the next question is from Peachy Luna. This is Vivian. This is about the job of radiographers. Of course, is about reject analysis. The question is the manual reject analysis is 5% or 2% the rate to be used daily, weekly, or monthly analysis? What's your reject analysis rate that you use?
In our quality control menu, we hope maybe 5% is the minimum. Yes, but in our hospital, we hope our radiographer can limit our 2% reject because the Asian woman, the breast glandular density is very dense, right?
Okay.
If the glandular can take if the exposure to the glandular here and maybe induce the breast cancer, we can measure. So we hope the reject and repeat rate lower 2%. in our
Okay.
hospital.
Okay, that's good. I think with the system that you have at the moment, you have like after training, additional training for mammographer that they have to pass the criteria set up by your professional organization like TAMRT. This it is the way that you can control the quality of your people and quality of the work that you perform to your patients in Taiwan. And I believe this is a good example to other countries in the world. And thank you very much for very, very interesting program for today. And before we close the program, I would like the two presidents to give some words to the audience around the world, our colleague, our big ISRT family. President, do you first.
Okay, thank you. Thank you for giving this opportunity to share our experience. Thank you, the ISRRT, for giving this topic. And we also thank you, Ms. Tang. She's very strong. Thank you.
All right, thank you, President Tu. And President Wang, is now your turn.
Yeah, thanks, Mr. Napapong and Ms. Newman. Give the Taiwan's a great opportunity to show our some experience in mammograph, and we think that such as online seminar is a very good platform to make a global to make a just a technical exchange. And we also thank the ISRRT to give the Taiwan such a great opportunity to show our that show can show the Taiwan's a good experience. Thank you.
All right, thank you, President Wang. And Donna Newman, it's your turn to close the program.
I have to tell you that I listened attentively through the whole presentation, and it was excellent. I think it is a standard and a platform that many countries around the world can use as a best practice. And I thank the Taiwan Society for sharing their practice in their country. There is a push around the world to actually ensure quality control happens. You have just demonstrated what a high standard that can be implemented for quality control to ensure the patient is safe. You have demonstrated how to ensure that mammographers in the right manner. And I think many countries could follow your lead. And as always, we knew that you guys were a star and had high quality performance that you could share around the world. And I thank the Taiwan Society for coming with us with the ISRT, hosting this seminar for people and sharing this information with our members. I know that lots of people will watch this post live, and the education is just phenomenal. So thank you. I thank all of the viewers that viewed in, and most of all, I thank our experts from Taiwan for sharing their knowledge so that everybody can learn from around the world. Thank you very much. And everybody have a good evening, a good morning, or a good afternoon.
Thank you.
Thank you.
And see you next time. Goodbye. Thank you, everyone.
Bye.